It is 3 o'clock. I am going to wait just a minute because I know I've got folks coming in from the waiting room just to make sure everybody has time to come on in. But if you want to share where you're from in the chat, that'd be great to see what span of geography we've got going here. All right, we're going to go ahead and jump in. Thank you so much. First of all, if everyone could mute as we get started so that we are able to hear our presenters. I want to thank everybody for joining. This is our first of a 6-series special summer learning series. We're calling it summer. We know it's only the beginning of May. Brandy, it looks like you are not muted. If you could mute for me, that'd be great so we can hear everybody. The focus is on early Head Start. It's called Early Head Start Rising. This is really an effort on the part of National Head Start Association to really bring some attention to early Head Start as its own entity. We know it's a very special group of people that work in early Head Start, doing very specific work. And we think this is going to be a really important time for all of you. And what I've tried to do as I put this series together is to really focus on some areas that, while I was at the Office of Head Start, I didn't necessarily see those pieces addressed. They may have been, and I just missed them, but they're things that I think are pertinent and maybe off the beaten path. So, and by the way, I'm Debbie Bergeron. I am the Director of Community Engagement and Innovation here at NHSA. I was the Director of the Office of Head Start for about 3 years. Super excited to be here to share this with you. I want to talk a little bit about who we have on board today, and then I'm just going to let them take it away. Steve and Patrick, I met while at OHS when we were doing our roundtables around the opioid crisis. And it really was the pandemic that sort of shifted us, the focus a little bit there. But for about a year, we were doing some pretty intensive work around this issue. And he was really integral at bringing people together and connecting with Early Head Start. And he is currently the director of the Vanderbilt Center for Child Health Policy and associate professor of pediatrics and health policy at Vanderbilt University School of Medicine, and an attending neurologist at Monroe Carroll Jr. Children's Hospital there at Vanderbilt. But more importantly, can I just tell you about Dr. Patrick? Every time I talk about early Head Start and wanting to really connect with the medical community, his name comes up. So we know we're talking to the right person today. Very excited about that. And through Dr. Patrick, I was able to meet Dr. Miska Terplan, and I'm very excited to introduce you to this board certified in obstetrics and gynecology, in addition to medicine. His primary clinical research and advocacy interests lie along the intersections of reproductive and behavioral health. Dr. Terplan is nationally recognized as an expert in the care of pregnant and parenting people with substance use disorder. And that caught my eye because of the focus of Early Head Start in serving pregnant women. And it's something that I'm really hoping to bring more attention to, both within the Head Start community, but also outside of the Head Start community, because a lot of folks don't know that Early Head Start does serve pregnant women. So they are kicking us off here today, and I'm just going to turn the mic over because they've got a lot of content for you. Feel free, if you have questions along the way, to post them in the chat, and I'll do my best to keep tabs on those. And if we have time at the end, I'm sure they'd entertain some Q&A from all of you. So again, thank you so much for being here. I am going to turn it over, I think, to Dr. Terplan.
Yeah, so thank you. And Stephen, if you want to say something, like, so I'm going to talk for a little bit. Dr. Patrick's going to talk for a little bit. We're going to have some time for questions and answers. You can put stuff in the chat. I'm probably not going to look at the chat while I'm talking, but I think at the end of that, I'm looking most forward to like some discussion. So I'm sharing my slides, and yes, so I am trained as an obstetrician gynecologist. I'm also boarded in addiction medicine. So my work really lies along those intersections. I'm going to talk about sort of the pregnancy part, and then Dr. Patrick's going to talk about the newborn part, and all of it organized to some extent around substance use disorder. So I wanted to begin, with, just thinking about substances in human history. And almost every single human culture has used drugs to which people in the latter 19th, 20th century developed addictions to. And in the historical record, substance use is associated with women. As depicted here, this is a poppy goddess on the left from a people we don't know that much about, but is thought to be the precursor of Demeter, depicted here on the right, holding, grains of wheat, but also, if you look closely, opium poppies. But whereas, sort of substance use is part of human culture, addiction and drug problems are really modern. The first drug crisis was alcohol in the mid-1700s, and the second were opioids around the turn of the century. And this was really considered to be a disease, not just a disease of women, but of white women, upper class or upper middle class, who had been exposed to opioids initially from their physician who prescribed them opioids for the treatment of, quote unquote, female ailments. And you might wonder, how was addiction understood at this period of time? And it was understood as a disease. The framework that was laid out by Dr. Benjamin Rush in this inquiry here on the right-hand side, he's considered the father of addiction medicine. He signed the Declaration of Independence. Like many people who did, he also owned enslaved peoples. And he described alcohol as alcoholism. And that same framework was used to talk about what the illness was called morphinism, seen as a medical condition, treated like one. Short-acting opioids, which were all that existed, were given to people for the treatment, not just of, quote, detox, but also to continue sort of for treatment of opioid use disorder. And around the turn of the century, there were clinics to treat addiction, some of which were actually embedded in police departments. And as Dr. Patrick pointed me 2 years ago, the first case of neonatal abstinence syndrome, withdrawal after delivery, dates from this period of time. So this changes in the 20th century through the criminalization of substance use and use disorder. Basically, the passage of the Harrison Narcotics Tax Act rendered that early nascent public health approach to addiction illegal. And some 20,000 physicians were fined in violation of this act. And as a consequence, who we associated with drug use changed, from a white upper class or upper middle class woman to a man, to a non-white person, and to somebody in poverty. And we are today in maybe the third, fourth, depending how you count, opioid crisis. And like that first one, it is also iatrogenic, i.e. initially caused by physician behavior. And this is the slide that CDC published that labeled the crisis as a crisis. The green line is the number, the volume of opioid sales. The blue line, a parallel increase in drug treatment admissions for addiction to opioid, and the red line, a parallel increase in drug deaths. What you might not know is that prescribing peaked shortly around the time that that was released, and has been declining over the last decade, unevenly across the United States. And certainly we still prescribe at a higher level than we did in the 1990s, but prescribing has been decreasing. However, overdose and overdose deaths continue to increase. And this is because the epidemic is shifting from first prescription opioids to heroin. And for the last 5+ years, depending where you are in the United States, the overdose crisis is predominantly driven by synthetic opioids, including fentanyl and other substances. And in this, we've witnessed another sort of big shift, right? A return to the medical and public health lens of addiction. No longer, do we associate substance use with like race or class or gender? We have what I would call this sort of universal language of whiteness. Addiction can befall anyone. It doesn't matter where you live, who you are, and etc. And although that is true, this sort of language, this sort of whiteness minimizes the actual real differences between men, women, Black people, white people in terms of the consequence of using a substance, access to treatment, and availability of recovery resources. So I'm going to talk, this was the groundwork of drug policy upon which opioids in pregnancy happen. So just as there is an opioid crisis, opioid use has increased across the United States, so too amongst people presenting for their birthing hospitalization. And I want to illustrate what it's like to be pregnant and have a substance use disorder through this story this is somebody I took care of several years ago, Lindsay Jarrett. And this was an article that was big in the New York Times about her having a substance use disorder and losing her child to the child welfare system and her struggles for reunification. And I want to share with you really what the comments were in when this was posted. Using H while pregnant is the deal breaker. Sorry, lady. Sure, the parents love the child, but do they love him more than heroin? As someone in a similar situation, I have no sympathy for her. You use drugs, you do not care about the child, period. And probably the most succinct and salient, some people should not be allowed to have children. So sometimes we look at things like this and we say this is stigma. But stigma is really a term, it's a mark of otherness. It relates to stigmata, the wounds of the crucifixion of Christ. In other words, stigma is a them problem. I prefer the terms discrimination or prejudice because this is how we treat other people. This is an us problem and actually something we can do something about. But one of the ways that we articulate prejudice is through punishment. Sort of in parallel with the second wave of drug policy, the so-called war on drugs, the first person who was in pregnancy arrested and incarcerated for using drugs was in 1977. And almost every state has arrested, prosecuted, convicted, and sentenced somebody for using drugs in pregnancy. And when we look at what's happening at the states, we can see the weight of state response bends towards the punitive, which are these first three rows. There are 23 states in the District of Columbia in which using a substance in pregnancy equals child abuse in state statute. And there's far fewer sort of more supportive state policies, which would be the bottom three rows. So in place of punishment, there are three questions that I want to walk through. Why would a pregnant person use drugs? Are there alternatives? And how can we do less harm? So I think the question, why would a pregnant person use drugs, is misplaced. Most adults in the United States have used substances to which some people develop an addiction. So the question isn't why somebody would use a drug. The question is what happens when people who use drugs get pregnant and stay pregnant. These are data from the National Survey of Drug Use and Health. The blue column is not pregnant reproductive women. The next three are by trimester separated by substance. And you can see people is past 30-day use. People who are pregnant report less recent substance use than people who aren't. Use decreases across the course of pregnancy and differs by substance. People cut back alcohol the most, cigarettes the least, and illicit substances somewhere in between. So I look at this, and to me, this supports the statement that everyone who's pregnant is motivated to maximize their health and that of their baby to be. Nobody thinks smoking cigarettes is a healthy behavior, much less in pregnancy. Some people can stop, other people can't. Those that can't likely have an addiction, likely have a substance use disorder. So when we talk about pregnancy and addiction, we are not talking about people who within the gestational window develop the disease of addiction. I've never seen that. What we're talking about is where, a life course of reproduction, getting pregnant, staying pregnant, delivering a baby intersects with use, proceeding to misuse, and then to addiction, and within a specific period of time. So are there alternatives to punishment? Of course, treatment. We have actually great data dating back to the 1970s specific to how to care for people who are pregnant with a use disorder. And all of the early and even contemporary literature demonstrates the same thing. If we treat addiction in pregnancy, we improve birth outcomes. This is like copacetic with one of the core principles of prenatal care. Healthy mother equals healthy baby. Optimizing chronic disease management in pregnancy improves birth outcomes. These are data here from the state of Massachusetts, and you can see the people whose substance use disorder is treated, their birth outcomes look much more like a population without addiction than in the untreated state. And it's these benefits of treatment from which pregnant people are described as a priority population in federal documents, like they should be given priority access, no waiting list, and etc. But despite this, most people with a substance use disorder in the United States today receive no treatment. Only a third of people with opioid use disorder report receipt of any treatment in pregnancy. And even if they do get treatment, is it evidence-based? Only 50% of people who are pregnant admitted to a drug treatment program for the treatment of opioid use disorder receive medication, which is the standard of care. It is safe and effective and recommended. And this is to some extent because there just isn't capacity to treat people with opioid use disorder in general, much less in pregnancy. And these are two studies looking at the percentage of obstetrician gynecologists who have an X waiver, which means they're able to prescribe buprenorphine, one of the medications to treat opioid use disorder. 0.4% in 2012, 1.8% in 2020. This is embarrassing. This is a failure. So putting this together, you've got the universe of people who are pregnant with opioid use disorder, maybe a third receive treatment, of whom only half receive medication, of whom a much smaller proportion receive, comprehensive co-located services that were described in those articles from the 70s. So finally, how do we do less harm? I think we have to focus on language and the language we use. That New York Times story is a good example of what I would call a dehumanizing discourse. And we counter that by humanizing our language, by using language that is both person-centered and evidence-based. Person-centered means person with substance use disorder, a person in recovery, not referring to people by their disease states. And evidence-based means using terms like substance use, misuse, use disorder, and addiction. The second thing is to center on the diet, and I think all of you know this well. And I'm just going to share this quote, if you don't know it, from Dr. Winnicott, who was a pediatrician who became a psychiatrist. He described the blankie, the attachment a child has to an object, and he said there is no such thing as a baby. If you set out to describe a baby, you will find you are describing a baby and someone. A baby cannot exist alone, but is essentially part of a relationship. So the final thing is to really just hone in on when I say care needs to be both evidence-based and person-centered. And what I mean by evidence-based is grounded in science. And I will say across this topical area, we exaggerate the risks of illegal substances, and we minimize those of legal ones. We also overstate the importance of the intrauterine environment and neglect the role of the caregiving environment, which is precisely where you guys work, which is why it's great to talk with you. And the second thing is person-centered care. This is ethical, this is grounded in human rights, this is the understanding of reproductive health as a human right, the right to determine whether and when to become pregnant, as well as the right to raise children in safe environments. And so we need to support autonomy and maternal subjectivity in decision-making and remain attuned to the unique demands we place on pregnant and parenting people, on their bodies and on their minds. With that, thank you, and I'm going to hand this over to Dr. Patrick.
Thank you, Miska. I'm going to pull up my slides here. So it's great to be with you all. I'm a practicing neonatologist at Vanderbilt Children's Hospital, and I'm going to talk a little bit about things from my perspective as a pediatrician and neonatologist that have shifted a little bit over time. And I'm going to start a little bit on kind of our perceptions of infants who are substance exposed too. So this is where I come in, and this is probably where many of you come in as well, even though we know that pregnant women can certainly enroll in early Head Start. Oftentimes we miss them. This was my introduction into the opioid crisis too. It was through my patients and seeing infants having opioid withdrawal. And in many ways, seeing them being treated differently than other infants that I care for. And I'll just place a couple points on that. So here's an article. Mom gives birth to a record 15-pound baby. And if you look at this baby, you can see this baby's getting a lot of support in a neonatal intensive care unit, respiratory support, but this baby is described as a miracle baby. Well, this is complicated, uncared for diabetes often in my world. But we see this baby as a miracle baby. If you fast forward to how we talk about babies who have opioid who have withdrawal, we see them as born addicted. The narrative is completely different, and that sort of permeates the way we treat and talk about infants. This is from one of the recent lawsuits too, the tragedy of opioid addicted infants. You know, we know more and more, and Dr. Terplan laid out really nicely that, you know, addiction is a chronic relapsing medical condition, and so is diabetes. And yet we treat them completely differently, and we silo addiction treatment in ways that I think are really problematic for both pregnant women and for infants. And Dr. Terplan already sort of talked a little bit about this too, but the way we view things fundamentally too has shifted over time as we've seen the opioid crisis be the thing that we talk about now. We are fundamentally viewing substance use different. Now, certainly science has changed over time, but systemic racism certainly plays a role too. And I think we know that we underemphasize again alcohol. 1 in 10 pregnant women use alcohol. About 16% still smoke cigarettes. And I think our goal should be healthy moms and babies, which is really talking about all substances with that goal in mind. I want to talk a little bit about the first piece that Dr. Terplan mentioned, which was treatment. And this was a study that we did where we had actors trying to get into treatment. Half were pregnant and half were non-pregnant. These were identical women. They were randomized. It was a randomized field experiment, so we could see what was it like actually on the ground. And as Dr. Terplan mentioned, medications for opioid use disorder, this is from the National Academy of Medicine, they save lives. The evidence is pretty clear. So the way I think about this is that if you have a woman who is using heroin, both her and the fetus are going through these processes of intoxication and withdrawal, What these medications do, they level that out, and it is less stressful both on mom and the baby. It enables mom to achieve recovery, and it also makes it more likely that that baby is going to go to term, and that's a win. Essentially, what we're trading off are infants who are born very preterm, whose mom wasn't able to get into treatment, for infants that are bigger but may have some drug withdrawal. So that's something we would want. So what's it like if you're pregnant trying to get into treatment? So we had 10,000 secret shoppers who tried to get into treatment. And we use publicly available, what HHS says you should go to try to get into treatment. Among our secret shoppers, about 25% tried 5 times or more to reach someone on the phone and weren't able to reach anybody. Another 20% got someone on the phone, but they found that that provider didn't actually provide addiction treatment, meaning that they had gone through the waiver process that Dr. Terplan described before, but they decided they weren't going to prescribe anymore. And then you can see the breakdown of pregnant or non-pregnant throughout the rest of the piece. So what happened? These are the 10 states that we focused on. And here you can see pregnant women in blue and in orange, non-pregnant women. And non-pregnant women had a much, if they were able to get through, they were 17 percentage points more likely to get an appointment. And the question is, how did insurance modify that too? So we know that when patients called, they either called with Medicaid, private insurance, or if they were denied, they would say, hey, I can pay cash. Here's what we found. We found that only about 40% overall were able to get an appointment with their primary insurance. And it really wasn't that much about Medicaid or about private insurance. It was really about cash pay. About 25% of callers could only get an appointment if they paid cash. And the median cost for that first appointment was $250, out of reach for many patients. So even though we know treatment works, it's really hard to get throughout the United States. And here's some of the experiences that the callers had. We had, again, these were actors, but the actors had, we sort of like when we met, these were our kind of in our study team, their experiences. And after they made calls to try to make appointments, they sort of described their experience. Here's one. People usually don't show up for appointments because they decide they want to go for one last hurrah on dope before coming. This is what somebody called when they were trying to get an appointment. A pregnant woman called, and what they were told on the other side of the phone was absolutely not, would not treat you. Another pregnant woman called and was told, whoa, we don't do that here. I won't get into that mess again. Another one was told that they would potentially kill the baby and go into convulsions if they didn't follow the treatment protocol. This was on the initial call. Can you imagine being a pregnant woman, going through the processes of trying to make the appointment? The barriers to get that appointment, only about 40% were able to get an appointment on their first try. And then this is what you receive on the other end of the phone. We also asked in a different series, like, what does language actually matter? We randomly, this is part of an ongoing project we have looking at public opinion on things, but we randomly selected in a poll that we were doing, half of patients, excuse me, to get a clinical vignette where we described a mother as an addict and a baby as born addicted, and the other vignette, a mother with opioid use disorder and the baby developing drug withdrawal. And this was in my home state of Tennessee. And here's what we found. We wanted to know, like, did it matter if they heard stigmatizing language versus not? And honestly, in this study, we found that basically it didn't. And that's because people's feelings, regardless of if the woman was in recovery and in treatment, were about the same. Most said that the baby should be placed in foster care, and about a third said that the mom should be arrested. So moving ahead, I want to talk a little bit about the infant's experience and a little bit about some of our care models as well, and how we've really shifted care over time. So what is neonatal abstinence syndrome or neonatal opioid withdrawal syndrome? It's a withdrawal syndrome experienced by some opioid-exposed infants, but not every one of them. And there's some important factors that modify an infant's risk of developing drug withdrawal. Some of them are additional exposures. We know if there are other substances, including cigarettes, benzodiazepines, gabapentin, other medications that can make withdrawal worse. We see in our own system too, lack of access to treatment can also make withdrawal more complicated. When women are in treatment, everything is better. In our own system, mom's more likely to leave the hospital with her baby as well, and not in foster care. Postnatal factors also seem to matter in terms of the development of drug withdrawal. Lack of standardization, exclusion of the mother, and not allowing breastfeeding. All these things can make withdrawal a little bit more severe at the time of birth. So the clinical features, what does this look like when you have a baby who's having drug withdrawal? And so the way I usually think about this is where the opioid receptors are, and they're in our guts. So babies who have withdrawal, particularly severe withdrawal, they can have poor feeding, vomiting, loose stools, and this can lead to dehydration and poor weight gain. Some common central nervous signs are tremors, so shaking a bit, increased muscle tone, irritability and decreased sleep, and exaggerated reflexes, like the very cute moral reflexes that babies do. And then some other signs, like breathing fast. We know that the rate of neonatal abstinence syndrome has grown in the United States, and this is in parallel with other opioid-related complications too. So this has been an increasing problem, and despite that, we really haven't seen resources like connecting to treatment. That hasn't changed substantially over time. To treat drug withdrawal in babies, the goal is really to control the withdrawal to minimize complications and to do non-pharmacologic interventions like I'll talk about in a second. We know these really work. Rooming in, having mom be with baby, breastfeeding. Also, there's good evidence that breastfeeding also reduces severity of withdrawal. And this isn't really about, this is about not just the actual breast milk, but it's about breastfeeding and about the bond that mom gets with baby too. But for infants who have severe withdrawal, we use an opioid like morphine or methadone to wean. And in our system, about 20% or so require a medication to treat their withdrawal. But there's been shifting models of care. I work in a pretty active neonatal intensive care unit. We now have about 120 babies is our capacity now, and we are pretty routinely in the triple digits in terms of babies in our unit. And at one point in the last couple of years, we had about 10% of our unit with babies who had opioid withdrawal. And so we really kind of reassessed what we were doing and how we could do it differently. The traditional way we've cared for this in the past has been we transfer a baby to a tertiary care facility. We separate mom and baby, and we place the baby in a neonatal intensive care unit. And the important thing to know about babies that have drug withdrawal, they need medical care, but they are not critically ill. The babies that I take care of in the ICU are babies with complex birth defects, babies on heart-lung bypass. These babies, the way I describe them is it's like a colicky baby times 5. They're a very fussy baby, but they are not critically ill. Treatment's been separated from the mother, breastfeeding not allowed or at least inconsistent. We've traditionally focused on the correct medicine. Do we give morphine? Do we give another instead of the care process? Burnout is common. There's good literature on burnout and nurses carrying this population. There's been a lack of trauma-informed care processes, and care has not been standardized. And what has this resulted in? It's resulted in very long hospital stays. If you look in the literature, we're talking months in some cases. But what's changed? And this is what's changed for us. The newer care models really focus on keeping the dyad together. Transfer to a tertiary care facility may not be necessary. Keeping the maternal infant dyad, the mom and the baby together, intact is prioritized out of the NICU when possible. The new guidelines that we released from the American Academy of Pediatrics highlight that care in the NICU is not required. Treatment's inclusive of the mother. When we engage mom in the care processes, including the scoring of her infant, things get better. Breastfeeding is encouraged and supported. We focus on the care process, not just the medications, and we engage staff in trauma-informed care processes. We standardize what we're doing. So what we've seen at Vanderbilt, so we, about 3 years ago, we shifted our model, and we call this Team Hope, where we had physicians, nurses, social workers, child life specialists, lactation consultants, and volunteers. And we thought we could do this better. And we had teams from OB, newborn medicine, the NICU, and hospital medicine. So we've shifted all of our infants born greater than 35 weeks who are in the hospital just because they've been exposed to an opioid outside of the ICU and in the newborn nursery or to our general inpatient floor. And we prioritize keeping moms and babies together throughout the entire hospital stay and focusing on resources for the dyad. So we have child life who sees them. We have a lactation consultant who sees them earlier. We really focus on the environment and the mom and the baby. And what we've seen is we treat about half as many babies with morphine as we used to, and our hospital length of stay is about half of what it used to be. And we still, we have moms and babies in our system. We are not seeing a big increase in the hospital readmissions or anything like that. What we are seeing is happier providers and happier families too. So we've had about 350 opioid exposed infants in the last 3 years. This summer, we're launching a program called Firefly, and this is funded from the Centers for Medicare and Medicaid Innovation. And it is focused on comprehensive care for the pregnant woman and a pregnant woman with opioid use disorder and their infants. And based upon feedback from both the community as well as Moms in Recovery, our tagline is lighting a path for moms in recovery and their babies. And starting in July, here's what we're going to be trying to do. Provide comprehensive and wraparound care for moms beginning early in pregnancy, where we address mental health, infectious disease, addiction, and prenatal care. We start early with engaging the pediatric with pediatricians too, including lactation consultants. We're providing enhanced addiction treatment, including an intensive outpatient program. In the hospital, we're still focusing on how can we optimize what we're doing, rooming in with baby, making sure addiction medicine's engaged, providing risk-appropriate care, and then making sure we connect with services afterwards, including with early Head Start, home visitation, and developmental monitoring. All of this is built upon a core of peer recovery specialists who are acting like navigators throughout the entire continuum. We are essentially trying to build something to address a lot of the issues that at least we've seen both locally as well as in our team's research. The other thing is that context really matters. So the last part of this, and Dr. Terplan and I wanted to have lots of conversation, lots of ability for conversation. I'm just going to close a little bit with talking about context in terms of communities, in terms of history, and then I'll talk a little bit about child welfare. And just ask folks to mute if you're just for this portion. We can have a discussion here in a little bit too. This is my hometown. And this is it's a town in the southern portion of West Virginia. This is a Friday afternoon just before the pandemic. And this is downtown. And you can see what's going on here. There's not much going on in my downtown. Here, the population is about half of what it was in 1960. Jobs have been harder to come by. There's the rate of overdose death in this community is 3 times the national average, and about 5% of babies born here have drug withdrawal. So the community matters, and some of these community effects are important too. There's a group of economists named Case and Deaton who've done some work looking at deaths of despair, and part of their argument is that lack of opportunity, lack of social network, lack of jobs has led to deaths from overdose, alcohol, and deaths from suicide. Our group wanted to know, hey, was this happening among maternal child health too? Was this happening for infants who had opioid withdrawal? So this is a paper that we published now about 2 years ago, looking at 580 US counties. And we wanted to understand what were some of the factors that were associated. And I'm going to share a couple here: long-term unemployment, as well as access to mental health. The first thing I want to show you is just, and you can see in the bottom left here, the states we looked at. It was 8 US states, 580 counties. But I'm going to focus on 3 states. And first, we're just going to show what has happened with neonatal abstinence syndrome. This is neonatal opioid withdrawal syndrome over time. And the darker the blue, the higher the rate of neonatal abstinence syndrome. And what you can see is a big increase, and disproportionately in this area in rural and Appalachian communities too. And during the study period, there was an increase in long-term unemployment. We term this as a moving average of the last 10 years unemployment rate. So it gives you not just what's happening in terms of unemployment now, but what's been happening over the last decade. And during this time period, this is during the Great Recession, there was about a 2 percentage point increase in long-term unemployment in these counties. And this was associated with, after accounting for all other factors, this was associated with higher rates of neonatal abstinence syndrome, and particularly in remote rural communities. So about a 2 percentage point increase in long-term unemployment was associated with a 34% higher rate of neonatal abstinence syndrome. And we found that mental health shortage areas were also associated with higher rates of neonatal abstinence syndrome, particularly in urban communities. I'll just mention that you can see this on our website too. And we have multiple data visualizations. If you go to childpolicy.org, you can see all of our website. But if you do a /NAS, you can see how things have changed over time for the studies that the counties that we're in. And you can even modify, like, what would be the predicted effect of changing employment. So I just want to talk a little bit about maternal drug use, because I think part of it is that we think, what is for folks in Head Start, for folks as we think about like our development clinics, what is the effect of maternal substance use on long-term development is a really common question, right? It's not a straightforward answer, and a lot of the literature is pretty confounded because it's complicated. Because maternal drug use doesn't occur in isolation, it often occurs in the context of poor health, poor nutrition, poor prenatal care, social stress, and intimate partner violence. All of these can be associated with poor obstetric outcomes, and each factor can also affect neurodevelopmental outcomes. Dr. Terplan mentioned alcohol earlier. Alcohol is common, it's more common than opioid use, and it is the #1 preventable cause of developmental delay in children. And we kind of forget about it sometimes. The role of toxic stress too and trauma. Trauma among women in treatment, about 3/4 report sexual abuse, similar emotional abuse, about half physical abuse. And when we look at adverse child experiences, they're also very common. We know that adults with greater than 5 ACEs compared to 0 are 8 times more likely to have substance dependence, and they're 10 times more likely to have ever injected drugs. So it's not a straightforward answer. And a lot of these long-term outcomes, they really have failed to account for additional substances, stressors, adverse child experiences, trauma environment, and mom's access to treatment. What is the effect of getting into treatment on long-term outcome? That's actually a question some of our research group has been working on. And in some studies, adverse outcomes may be a proxy for social and economic hardship, and that can be really difficult to disentangle. And I'll use this as one example. This is a study that found that that infants with neonatal abstinence syndrome compared to controls had worse testing outcomes. So this is from Australia, in grades 3, 5, and 7. But here's the problem. The comparison group was matched at the time of birth on gestational age, socioeconomic, and sex. We know that this is more complicated than those factors. We also know that things can change over time too. All right, what about child welfare policy changes? And I'll close with this so that we can have time to discuss. I just want to mention this because I think it's important to the context for the families that you all care for. And it's been a space where we've seen lots of changes recently. First, we know that there's a great variability in foster care placements nationwide. This is rates of foster care placement per 1,000 births by state. We know this grew from 2011 to 2017. And again, my home state of West Virginia has the highest rate of infant foster placement. It's more than 4% of infants in 2017 placed into foster care, most for parental substance use. Overall, if we compare how many infants were in foster care in 2011 to 2017, there's 10,000 more infants annually placed in foster care. And most of that, it just grew in parallel with the opioid crisis. But this space has been complicated, and it's complicated by what happens then. And I just want to talk a little bit about this, and we're going to talk about some policy changes. This is a study that was published last year looking at the association of state criminal justice focus, prenatal substance use policies, and reunification. And getting back to the issue of systemic racism, that really does play out in the way our child welfare system functions. In this study, they found that non-Hispanic Black children were 13% less likely to be reunified with their parents than non-Hispanic white children. And we see this throughout the child welfare system too. There's been some studies looking at who gets referred to child welfare. And in those studies, there were similar substance use patterns between white women, and Black women were 10 times more likely to be referred to child welfare. So what can we do about this? Well, there's been lots of recent child welfare changes over the last 5 or 6 years. And they've increasingly focused on preventing foster care placement by connection to treatment, including a development of a plan of safe care that many of you may have heard of, and other things like the Family First Prevention Services Treatment Act, which is a mouthful, to use child welfare funds for prevention. But here's the problem. This is in the context of chronic underfunding and shifting expectations and roles for state child welfare programs. In largely the vision of changing the way child welfare the way it works in the country has not really shifted substantially, at least on the ground where I am, despite federal changes. The American Rescue Act, I thought I would mention this because it has a lot of, it has more funds for this issue including money for the Child Abuse Prevention Treatment Act, for community-based prevention efforts. I wanted to mention too, there's $1 billion in there for Head Start. So I think there's increasing focus on our families, but we have a lot of work to do. Well, I think early Head Start's really uniquely positioned to empower families. And I think that's because you all break silos between systems. You connect, you see people where they are. The ability to sort of help families navigate and empower them. I just got the results from this today. From our treatment, we're working to launch this program in a little bit, and we surveyed some moms that were currently in treatment in our programs. Half reported childcare as a specific problem. And I think that the role of comprehensive, it's obviously not just childcare, but that sort of role of everything that early Head Start does, plus providing childcare, is so empowering to families. And I think part of this is teamwork. I mean, we need to do a better job of thinking about Head Start as pediatricians, as obstetricians. How can we do a better job of connecting? And so I look forward to talking to everybody. Here is my email address too. And thanks for your attention.
Thank you so much. That's a lot of information. I'm glad we have some time for some questions, because there's one in the chat. I'm sure people will put some more. I have a few too that I'd love to ask. The one in the chat asks about there being any data to show what happens if a mom goes through treatment. Do you see success in terms of her ability to care for children after that treatment?
Miska, do you want to start? So, I mean, yes. So we know even from our own data, there's that, I'm leaning back, I think because I'm thinking about child welfare now. We know that there's less likely to be a foster care placement. I think the point of this is that recovery is possible, right? Our team right now is trying to look at, because I think there's been so much focus on infants with NAS, this question of what happens between moms who are able to get into treatment and who's moms and who's not, and what happens to their infants long term. That's an area where we're studying right now. Mishka, do you want to?
Yeah, I mean, so you have those really nice slides looking at like how we think about really like the birth defect of untreated diabetes in pregnancy, and how we think about really the side effect of untreated or even sometimes treated opioid use disorder in pregnancy. There are, when we say addiction is a chronic disease, there's a lot that is behind that statement. There's stuff about brain science, like how it affects, and there's stuff of the brain science about what recovery does, the brain can heal, but also there's a similarity across different chronic conditions. The likelihood of recurrence and the likelihood of recovery is roughly the same for addiction, diabetes, hypertension, and asthma. So we say addiction's a chronic disease because it behaves like a chronic disease. I would say everybody has, their own kinds of strengths and weaknesses individually and collectively that they bring to bear in their families and their communities around child rearing. And I don't think I think untreated addiction is a public health problem, but I wouldn't say it is categorically incompatible with safe parenting. I think the better, clearly treating people with any chronic illness is better. And there's no evidence that people who are stable in recovery are, putting their children at any greater risk than anybody else. Although they've been placed under far greater scrutiny, than any other health condition would place them under. So I think what we kind of do in our head is we take the the organizational principles that underlie US drug policy that classifies certain things as illegal, and we say, since it's illegal, it must be so much more harmful. So much worse for the family, for the child, and et cetera. And that's not, this is a legal distinction, not a biological or public health one. So yes, there's nothing to indicate that people, can't parent to their full capabilities, with a use disorder, but especially in recovery.
Awesome. And we have another question here about mental health support. Is mental health support available to the mothers postpartum other than the blanket of social services? So is there support for these moms that you see?
So I think, just to back up a touch, I kind of think that we don't think we need to sort of reconceptualize pregnancy. We think about pregnancy as the time from, like, conception to delivery. But it's really that year after delivery, the so-called, fourth trimester, where, like, where mood changes occur. In many parts of the United States, overdose is the leading cause of maternal death. And part of the reason why there are these increased vulnerabilities postpartum is because we actually do not provide care there. And by we, I mean, people who are prenatal care providers. People are seen weekly up to the delivery and then maybe once in the subsequent year. That is mismatched. The pediatricians have done a far better job in this space, and maybe Steve, you can talk about, like, maternal depression screening in the context of pediatric visits.
Yeah, it is sort of, it's becoming more, it's more mainstream. It's more expected that pediatricians will look for signs of depression in mom. And so I think that is something, though. I think the question is what to do with it then. I think we're seeing some positive changes in terms of expansion of insurance, and particularly Medicaid coverage to 1 year postpartum, that I think will help. But we still have a chronic issue in the US with access to mental health services, period. And I think in many communities, if you're a kid, so if you are in Nashville and you have your child that has a mental health crisis, you may come to my children's hospital and you may sit there for a long time waiting for placement because there's no place for you to go. And so you stay in my hospital with just in the hospital waiting. So we struggle overall with access to mental health services in the US, particularly ones where insurance is accepted. But I think we're making subtle progress in that direction with expansion of coverage. I also think things like mental health parity have helped somewhat.
Yeah, I would agree. I mean, these are great. I mean, I agree. I support, expansion and parity, but we kind of sometimes confuse health insurance for health care. And just because there's coverage doesn't mean people get services. Just because now, like, many states have expanded, Medicaid for a year postpartum, that's great. But I don't think most obstetrician gynecologists are going to suddenly start seeing people in the postpartum period, like, I hope they do, but more needs to be done to actually to go from that, level of policy to actual care delivery.
This is such a good question. And this is kind of one that I had written down, but it's framed so beautifully. Matthew's asking that you all mentioned that EHS is in a unique position to reach out. And you're right. We are really a hub of most communities. That is all true. However, his point is, how could Early Head Start better connect with the parents that don't come to Early Head Start? Because the ones coming in the door are saying, hey, I know I need help. It's the ones that we can't find. And that's where, frankly, the reason I'm connecting with these folks so vigorously is because I think there is a lack of connection between Early Head Start and the medical field. So I'm hoping to tighten that. And so, Matthew, your question is fantastic.
I think some of this is exactly that work that you're doing, Dr. Bergeron. Some of this is awareness. I mean, we aren't trained, even as pediatricians and obstetricians, we aren't really trained to think about these things. And oftentimes we don't think about, I mean, if I went through and talked to pediatricians about early intervention services and they may know some of those things, but they're not going to think about Head Start quite as much as we should. And so part of that is breaking down some of the silos that exist to where we know what resources are available. I bet if you ask pediatricians and obstetricians, are pregnant women eligible for Head Start, they wouldn't have any idea what you're talking about. And so I think that's part of where this needs to build out. And I would say if you're in the Nashville area and you're a Head Start, give me a call. We've been really working hard to solve some of these issues locally. And so we'd love to partner with you locally too.
And Dr. Terplan and I sent you that blurb on Early Head Start when we first met.
Yeah.
I don't know if anything's happened with that, but can you explain to them what we're hoping we might be able to make happen? This is kind of promising.
I mean, this is, yeah, I mean, so this reflects, I mean, I am here because of that question. I'm here to learn how to better coordinate and to really bring Early Head Start into the clinical care of, pregnant and parenting people in particular who use drugs. But, and I recognize that this is an essential service, probably more important than anything, leaving aside like anything that I do, I would say. And yet one that despite, all the training that I had to go through and then, almost 2 decades of work, I know very little about. And my ignorance, I think, is reflective of a larger problem of disconnect. Mm-hmm. So one of the things that we had talked about was like just getting some very, very simple language about what Early Head Start is. And in my work with, professional societies and other stuff where we write a white paper and we're redoing one document to try and insert some language, that will be about the, that will elevate or include, I guess I should say more, we could work on elevating later, like the, just the presence of Head Start and Early Head Start. I think there's other opportunities to communicate this to, the professional societies and to clinicians. But that's just the beginning. Actually, I really, I welcome suggestions from you guys on how to make these connections better.
Mm-hmm. And I have to say, you all in my audience here, you have 2 incredibly influential advocates here and who really believe in this. So we do need to work as a community to help guide them and help make these connections and create some really good energy around this. I think the time is now to do it. It's very exciting. And Stephen, I think I cut you off. I'm sorry.
No, it's all good. I was just going to give, the American Academy of Pediatrics has done a fair amount of work with Head Start. And actually that's how we got connected initially. And I would just want to put that out there in terms of like, but I don't think neonatologists think about it. I'll just put it that way. But we put in the statement on neonatal opioid withdrawal, and within the American Academy of Pediatrics, we specifically called out Early Head Start as a resource. But I think to the broader point is I actually think for me, this is not a complicated medical problem to treat. It's just not. It's all these things that are more important. And I think as physicians, there needs to be this bit of humility of like, this is not like, this is teamwork, and this teamwork is outside the walls of my hospital. And those services are far more critical. And I think broadly, we have an issue across, this is my 2 cents, federal, state, and local government, where all of these programs are siloed. Like, what if there was a more seamless connection? Because we have under enrollment of other services like WIC too. What if all those things were easier to connect to? Because right now, I think half of our job is trying to coordinate those things.
Yeah. So our hope is to make these connections better. I want to thank both of you for taking time out of your busy day to spend with us. We did record this session, folks. I've had a couple people ask, and we'll make that available. I don't know if your slides are made available. Are you all comfortable sharing them? Hate to ask you that on the spot right here. That's kind of rude.
Yeah, as long as it's shared as a PDF and not as a PowerPoint, and as long as you recognize some of, I can't remember what images I have. I don't own the rights to them.
Very good. Very good. We'll work on that for you all. And also, just as we close up here, folks on the call, I'm going to put a quick, it's really quick survey in the chat. Will you please take it before you log off? Because this is the first of 6 series and the first of the EHS Rising campaign. And I want to do work that you care about and that works for you. And I can't do that if you don't tell me what works and what doesn't. So please take the survey. I'm going to stay on for a few minutes so you can get that link. I'm going to let my friends go. They've got busy schedules. Thank you so much. I'll be in touch and we'll figure out next steps. Thank you. Have a beautiful day.
Thank you, guys.
Thank you.
Bye.
And to everybody at EHS World, thank you so much for showing up. I hope you'll be here next time. We're going to work on identifying disabilities, early identification of disabilities. Super excited to bring in some specialists around that area, and we can talk about how we do that with the littlest ones. So thank you so much. Take my survey, please.